We'll get started. Okay, so hello and a very warm welcome to this Explain Pain in the Clinic. My name is Joanna and I am Director of Noigroup Europe. And I'm joined this morning, this afternoon even, by my good friend and Noi instructor, Ben Davies.
Good afternoon. Afternoon, everybody. Welcome to you all for joining us.
Thank you. Ben has been a Noi teacher for over 10 years, I think. Yeah.
We're pushing 15, Joe.
Oh, God, please don't. We met actually at a Lorimer Moseley course that Ben was running in Huddersfield. Is that right? Yeah. So that seems like we looked a lot younger then. So Ben's been a Noi teacher for well over 10 years, maybe nearer 15, and he has taught hundreds of Explain Pain courses to thousands of clinicians all over the world. He is an active clinician himself, working in the NHS. Now, I'm going to let Ben tell you what he does because I actually can't pronounce part of the words.
So I'm an NHS, I'm an advanced practice physiotherapist, and I specialise in persistent pain, and for the last couple of years in rheumatology. So in Bath, in the UK, we run a residential programme for axial spondyloarthropathy, AS, AXPAR. People come and stay with us from around England and come and stay for 2 weeks for the only residential rehab course for that condition in the country.
Yeah, amazing. It's an incredible resource that you have, isn't it? Facility, incredible. Thanks, Ben. So I'm just going to tell people what the session is about. If a lot of people have come week after week, but also there will be people who have not joined one of these before. They may be watching live or they may be watching on catch up. So these sessions are all about giving you a taste of Explain Pain and how to practically apply it in the clinic. Now, some of you will have done Explain Pain courses already, and so these sessions are designed to both reinforce what you've already learned and expand a little bit. And but if you haven't done a course, then they'll give you a very, very nice introduction to some of the things that are covered in the core courses. So just a couple of things to mention before we start. Ben will be talking for about 20 minutes. If you have questions, please pop them in the Q&A or the chat. I'll monitor those and we'll get to as many of them as we can. Sometimes we run out of time, but we'll do our best. If you want to watch the recording of this session, you can access it in the Noi Group clinical discussion group, which is a YouTube channel, and I'm just dropping the link to that into the chat now. Please do come on over and check out that channel because there's probably 20 or more of these in there now, and I am told that people find it a very, very useful resource. So also like and subscribe because that's it just means that you are notified when a new episode becomes available. So today we're going to be talking about active treatment strategies to promote recovery. What are you thinking you're going to cover in this session today, please, Ben?
So I was thinking about the difference between active treatment and passive treatment. I mean, I suggested this topic to you a few months ago, Joe, and in my head, and I recognise we've got a whole breadth of clinicians on here. We may well have people with persistent pain on here. People will work in different work environments, different specialisms. People work in the NHS, people work in private practice. So I was thinking about how do we pitch the difference between active treatment and passive treatment. I was thinking about what that means for the person. I was thinking about how we as clinicians engage people in as much active treatment as possible. And also, I suppose, why is the research and the evidence supporting active involvement rather than passivity? But also, where is the role for passive treatment? Where is the role for manual therapy and drugs and injections and things?
Okay, brilliant. Thank you. I'm really excited to hear what you have to say about this. It's a great subject. So let's kick off by could you tell me what you mean by active treatment strategies?
So let's compare and contrast, I guess. So I've sort of touched on this passive treatment, things where you as a person, as the recipient of some treatment, are not so actively engaged, but I think it's quite hard to define it. So something like taking medications, obviously you have to actively take the medication, but the drug is doing the role of the drug, hopefully. If you're having manual therapy, you're sort of lying there, you're a passive recipient of that treatment. If you're having an injection, whether that's a steroid injection intramuscularly for a rheumatological problem or into a joint, spinal epidural injection, you're a recipient of that treatment. Now, that doesn't mean those things aren't useful. Obviously, working in rheumatology, we have lots of people who take, a wide range of anti-inflammatories, analgesia, biologic, advanced therapies. And without those treatments, their life quality would be significantly impaired and their ability to engage in active treatments would be significantly impaired. But I think passive treatments are essentially a noun. You have something, you receive something, something is done to you by a clinician, by someone who's prescribing or injecting to you. And whilst they have their role, the person in pain is then not with that clinician for most of that rest of that day, the rest of that week, the rest of that month. What are we asking them to do? And I suppose the flip side of passive is active, and active treatment usually is a verb. You're doing something, or you can frame it in terms of a verb. So my list that I wrote down last night, active treatment in terms of exercise and activity. What do we want people to be doing for their particular pain problem? Diet, choices that people may be making around the food that they're putting into their body. So not diet for weight loss, but diet for fueling perhaps, or diet for what we think diet does to our body in terms of inflammation or recovery. People on this course will have heard, I'm sure, from their patient groups that the person has had CBT, had cognitive behavioral therapy, but do they ever say, I've done cognitive behavioral therapy? There's a difference in that noun versus verb. If you're going to do some talking therapy, you really need to do it. CBT is an active process. As a receiver of CBT, I've got to be thinking about my thinking. I've got to be understanding what my thinking is. I've got to be understanding what my, balance of positive thoughts versus negative thoughts for a certain context is. If I don't actively engage in that process, and there are other forms of talking therapy, it's not going to be as successful.
Would you see talking therapy then? Which side would you see talking therapy on, passive or active? Or does it depend on the individual practitioner, the CBT practitioner, or the talking therapist?
Yeah, I think there's a range of talking therapy, psychologically informed therapies. But I think the person receiving that always has to be actively involved. They've got to be, if a lot of our colleagues in Bath use ACT, acceptance and commitment therapy, as a model. Now, if you're going to kind of recognize unpleasant thoughts and diffuse yourself from those thoughts, if you're going to recognize that those thoughts are transient, and if you wait a moment, you'll have a better thought. If you're going to use the ACT model as a participant in that therapy, you've got work to do. But I think these things do overlap. So the clinician delivering that talking therapy, whether it's CBT or ACT, how they frame their role. If you're a clinician who's using something like EMDR, eye movement desensitization and reprocessing for PTSD, there is a bit of passivity in that. The person's receiving a sort of moving stimulus across their visual field, but they're also tying that into talking therapies and recognition of stress. So I think some things do sit in both camps, but probably the clinical benefit sits more on the active side of engaging with the talking therapist, not just lying there receiving, receiving some talking therapy. That doesn't make sense, does it?
No. Okay. So active versus passive. What's the difference then in terms of, so you've given some examples of both. So what's the difference of those two strategies for the patient and for the clinician and for their trajectory?
So if you look at the risk factors for persistent pain, and we often don't know why this person has developed persistent pain, with a certain injury or a certain life story, and the other person with the same injury doesn't develop persistent pain. But I think what we find in cross-sectional studies is that association with things like self-efficacy. You know, so
Mm,
self-efficacy is the idea of what can I do? Am I in charge of my, immediate decision making? Am I in charge of the direction my life is going? We find close associations with things like anxiety. And anxiety to me is forward-looking worry. Am I worried about what's about to happen? And am I concerned about my ability to cope in that situation that's coming up? We see close associations with depression. To me, depression is backward looking. Stuff's gone wrong for me in the past, and if I try this, I'm bound to fail again. And I know those are really simple kind of distinctions. I had one other I wanted to pick up: autonomy. How that's different to self-efficacy, but autonomy. Have I got choices? Have I got the freedom to make choices in my life around what I eat, who I go out with, where I go, the kind of job I apply for, the application for promotion or to change jobs? Or am I lacking that autonomy because my social world is pushing me around from pillar to post? I think
mm,
what active treatment does is try and help people develop self-efficacy and develop autonomy and develop that sense of that person in their own living life world, being able to make decisions for themselves and be able to kind of make choices. And I think lots of those choices are then, I suppose we would frame, can you be in charge of that pain condition? Can you be in charge of that rheumatological condition rather than that pain condition being in charge of you and pushing you around? I think what active treatment
mm,
does is to increase people's both conscious, and I want to pick up a thing I read in Ben Boyd's book, it's called Body Relearning, Bodily Relearning.
mm,
Not only can we make kind of conscious decisions, if I was a person in pain, can I make those conscious decisions to put certain strategies into practice that might be physical, that might be stress management, that might be dietary, that might be sleep and recovery, that might be communication with other people, so that I can sort of accept a certain amount of workload in work or at home? Can I delegate? As opposed to just me being unable to direct my recovery, whether that's an acute injury, or direct my recovery if that was a persistent pain state. Active strategies, I think, help the person consciously, initially, but also then subconsciously feel like they're in control and they're in
mm,
a position of being able to be safe and secure and able to make those decisions to develop their life back towards their life quality that they're aiming for and aspiring to valued
mm,
activities and work role and family role and social role. If you've got that ability within yourself, I think you can make those decisions. If you're relying on a clinician to fix you, that's not to say there isn't a role for manual therapy as an example, but I don't think that manual therapy has that same way of developing that self-belief that the
mm,
person needs to have.
mm. Yeah, really, yeah, that makes complete sense. So that sort of brings me on to practical ideas and strategies. And I mean, I'm imagining that some people are more open to active and being a participant in their own recovery than others. Um, I'm sure. Am I right in thinking that there's a big scale?
Yeah, absolutely.
Okay, so where assuming that somebody's sort of not perhaps right on the doesn't want to know, but just needs some gentle sort of encouragement, what kind of strategies do you have to assess their openness first?
Yes, absolutely. And actually, I think clinicians with some mileage in their clinical history will definitely recognise. And I suppose if I just cite this in like a musculoskeletal, clinical type scenario, people come into our clinics in the NHS, come into private practice, and you really quickly get the sense that someone wants you to fix them. You really quickly get that sense that someone just wants you to, use your physiotherapist's magic hands or your osteopath's, your chiropractic manual
Mm,
magic hands to fix me. And like I'm saying, I think there's a role for that, and depending on their unique situation, there will be more or less a role for manual therapy. We also get the people who are really at the other end of the spectrum, who kind of come in wanting strategies, the people who are really keen to know about diet and exercise. And I suppose they're at the other end of the spectrum. We almost don't need to worry about leading them to this because they're already wanting that. So the people at the other end of the spectrum are rare. It's the people in the middle. And depending on the clinical situation, how do we pull people towards that active engagement? I think it's part of that clinical artistry of being, a clinician of increasing experience in years. I think I definitely put a lot of that within the motivational interviewing sphere. So MI, I say simple, communication strategies that are very much worded to help us as clinicians understand where the person is in terms of their intrinsic motivation to kind of take ownership of health behavior changes, but also how can we lead people towards, maybe one step more towards active engagement than they came in with. And that's things like offering choice, so I've heard your history, I've taken your history, I've listened. Okay, from all of this history, I think there's a number of things that might be worth thinking about. We might have treatments at this end, we might have dietary advice, we might have exercise advice, maybe some medication. Conversations need to happen depending on whether people on this call are prescribers or you liaise with family physicians, GPs. And offering that choice to somebody innately almost helps them begin to have the choice to then make a choice, or the opportunity to make a choice as to where where that person thinks they've got some control over. Now, as a clinician, we might kind of want them to choose strategy A. Maybe they choose strategy B, and maybe that's okay. Maybe that's enough. Maybe that choice that's come from the person chooses, actually, could you teach me a relaxation strategy? Yeah, I could do that. Here are the options within relaxation. Which do you think might sit with you in terms of your preference, your use of relaxation apps or CDs or Spotify or YouTube or cost? These things will all become part of do you want to do this in person? Do you want to do this recorded? But what we're aiming for is that person actively goes away and puts that relaxation into practice. So maybe we give people some choice, and that choice from the person begins to build their confidence. And then the next time you see them, or whenever it's appropriate, so how are you doing now? What's the next choice? Well, now I'm sleeping, now I'm relaxing, I'm sleeping better, I'm feeling more recovered. Maybe some exercise would be the next step. So we're building that ability for somebody to make choices themselves, to guide themselves on that road to recovery, with us being facilitators of that rather than us doing the fixing.
I love that. I haven't heard that before in those terms about the importance of choice in getting somebody's buy-in to a process. I love that. It sort of simplifies a lot of complex stuff, doesn't it, down to a word that you can potentially draw on when you're trying to find a way forward.
So you've had your girls are growing up now, but when they were young on an MI course, it was phrased in terms of, if you say to your kids, "Come on, kids, you've got to come in for dinner." "No, I don't want to." "Kids, do you want to come in through the front door or the back door?"
Yeah, closed questions.
We open up that choice. We give them the choice. Kids will come in. But if we sort of say, "You must do this," then the kids will go, "No."
Yeah, it's such a simple strategy, isn't it? I totally remember using it. Do you want a bath now or in 5 minutes? Exactly the same. Okay, we've
Well, I'll
got a
come in
question.
5 minutes, Mum. Okay, well, in that case, that's fine. I'll do that. I think it's the same sort of, philosophical approach or psychological approach. Joe, I'm aware of time. Can I just, so this isn't, this is product placement, but I'm not deliberately product placement. So Ben Boyd's book, Bodily Relearning. Joe, you sent me this, I have to say, months ago, and various things. I've only got around to reading it sort of recently, but there was this little quote that I just wanted, I felt kind of summarize this.
I'll get my copy and I'll hold it up.
Right. The quote is,
Go, I can still hear you.
so we, patients, somebody in pain, we are more than the sum of our complex computational processes. Our experience is not predestined or predetermined by the circumstances of the moment is an important message. Our available choice may initially be solely within the conscious realm. You know, we have to choose to practice relaxation or to choose a certain dosage of exercise in collaboration with a clinician. However, we use conscious approaches to help retrain the non-conscious approaches, the stuff that's happening in our backgrounds that makes us feel threatened or protective, generates fatigue, generates pain, generates, you know, changes in your digestive system. That stuff happens subconsciously. Nobody chooses pain. Nobody chooses, you know, poor sleep. It's sort of subconscious balance of the bio, the psycho, the social variables that are that the person's sitting in at that moment. Now, we can't change that directly, but we can change their conscious choice about how they begin to make small step changes towards being more secure, being safer, being more autonomous, having greater self-efficacy, having greater ability to kind of choose different variables. I remember Mick Thacker, some people will know Mick. Mick said, people need three things in persistent pain. They need physical flexibility, they need thinking flexibility, and they need behavioral flexibility. And I think it's those latter two, you know, that we're really trying to help people begin to sort of train with those active strategies. They can then choose how they choose what they do, choose, you know, maybe who they engage with and how they practice calming, restorative practices, as well as choosing when they're stressed by work and by life and by physical exercise. We've got to kind of get that balanced. And the more the person can be in charge of that sort of decision making, the more they can continue that process when they're not with me as a clinician. We see people for these 2 weeks, but we constantly are saying, look, how are you going to choose these exercises when you're not here? 2 weeks, 10 working days with a bunch of people is a really unusual, unique therapeutic environment, but you're not here next week. You're back at home. How do you learn how you make these choices about AXPAR management, AXPAR self-management, so that you can use the drugs in collaboration with the non-drug stuff to get best quality of life and minimal pain that's you know, achievable, maximum quality of life, maximum freedom to choose the valued things in life, because that's really where I think quality of life comes from.
No, really so much. Thank you, Ben. That's really, really great. I love that quote that you wrapped it up with there. Beth is just asked if we can provide the quote. And the link's not working to that. I'll sort that out in a second, Michelle. And Beth, the quote will be in the recording. Can you tell me whereabouts in the book that quote was?
So it's in section 1.2.2. It's page 6. There's in the left-hand paragraph, because it's two columns, sorry. It's the bottom of the middle paragraph. Page 6.
Okay, lovely. Page 6 in the book, and I'll get the right link now. Apologies for that, folks. Sorry. I'll get the right link. So we've got two questions, Ben. Lonique, regarding an autonomy and self-efficacy, where do you see the line between the support of a physical therapist and the support of a psychologist? Great question.
Yeah, it's really blurred, I think. It very much depends on the discussion between you and the clinician, you and the patient, as to what the level of psychological distress is. And I think there's three, maybe 4 layers. You're an empathic human being. Can you normalize that person's psychological distress? Because of course you're worried about this prognosis, this condition that's been diagnosed. Of course you're, you know, depressed to a certain extent because life hasn't been great. You know, as an empathic clinician, is this person, can you just, you know, if you like, deal with that level of psychological distress because of your empathy? Maybe not. The next level up, I think, is using psychologically informed, I'm going to say physical therapy, but OT, chiropractic. Do you have some training in CBT or ACT, even if you're not a CBT therapist, but you can just work with those models a layer up? Do you need to link to official talking therapy services. In the UK, in England, we'd have talking IAPT services, improving access to psychological therapy, low-level CBT, low-level, sort of online support services. Do you need to co-manage somebody or co-support somebody with someone who has psychological training that is in and above what you have? Does that person need a psychologist? And I think that will be factors like, child abuse, sexual abuse in a relationship, really, high degrees of bullying, high degrees of self-harm, when we just kind of go, do you know what? This is over and above what I, as a physio can deal with. And I think the language to use there is, have there been things that are difficult in life to cope with? And then you can talk about those things to a degree, but getting a sense of when somebody needs, or when you as a clinician need that psychological support, is quite a movable frame.
Yeah, I agree. I think I heard somebody say, if in doubt, then seek help.
Yeah, absolutely. I mean, what we don't want to do is have a service user, patient in front of you who discloses some, suicidal thoughts, childhood abuse, marital abuse, whatever it might be, and then you sort of end up going and over to the other service. They have sort of told you that level of detail because of your empathic communication style and safety that you've created within that assessment period of time. You've either got to deal with it, or you've got to have the right resources to co-support that person.
Yeah, really well answered. Thank you, Ben. And then a last question. Choices are a brilliant way forward. This is a question from Stuart Cameron. Choices are a brilliant way forward we have in our pain service. The more there are, the more patients feel they are in control. As a prescriber, physio, and acupuncturist, I can offer a wide range of options along with Tai Chi, exercise groups, and mindfulness as other options in our service. Wow, that sounds incredible. So it's not really a question, just like letting us know what great options.
I think that's great. I mean, physically, within our sort of, the physical aspect of most of our AXBAR course is kind of physical health with a nod to psychological health for living with a long-term condition. But also, look, we want you to be fit, strong, and flexible. Within flexibility, let's just take that one. How do you get flexible? Chair-based stretches, Pilates, Tai Chi, yoga. Which are you going to be able to do? Occasionally, I've had people say, well, I can't do yoga because I'm a Christian. And inside, there's a bit of me that goes, really, it's just movement. There's no religious aspect to yoga. But if that's not for you, that's fine. Let's find another way. The most important part of how do you keep flexible with AXBAR is which exercise approach are you going to do most days of the week for the rest of your days? And I don't really care what school that movement comes from. I just want you to do it. And if you've chosen Tai Chi, brilliant. Let's give you some resources, YouTube channel, local classes. If you're in a central urban area, Tai Chi classes are much more likely than if you're in some rural area, but that's not a definite, is it?
No.
So great range of options, Stuart, and keep offering those choices.
Yeah, amazing, Stuart. Wow, it sounds like you work in a great place. Okay, so we're just going to wrap up now. Thank you, Ben, for all that. I really enjoyed that session. And as always, you make very complex things, very understandable. And if I can understand it, then everybody in the audience will be able to understand it. So thank you so much for giving us that insight, that little sneak peek into the explain pain approach. And just on that subject, as I said earlier, these sessions are designed to give you either an expansion if you have already done a course, but if you haven't already done a course and you're thinking about doing a course, then I'm just going to ask Ben to briefly explain. He has 2 courses coming up. He has a 2-day online explain pain in October, and he also has a 6-session night school explain pain. So Ben, if somebody is thinking about joining the course, could you just give me a little idea about the difference between the 2-day and the 6-session course, please?
I was. I mean, essentially very little. The content is the same. The workbook that I use to Muses through EP is the same. The slides are the same. We just order it slightly differently. I've sort of come up with a way that just breaks things into a 4-hour Saturday morning, so kind of half a day, and then with these 5 2-hour Thursday evenings. I think the main thing, Joe, is 2 days online is quite hard.
Yeah,
2 days of pain science on Zoom is not easy. And so if people feel they've got, screen fatigue, or they want to think about this sort of topic more, with the night school version, people can, there's a little bit of homework, between this section and the
yeah,
next section, could you read this paper? Between this session and next section, could you try a motivational interviewing offer of some topics to a patient? So
yeah.
it allows a little bit more practice through the course, but the content, the science, the range of sort of stories to tell, the rationale, the sort of assessment for EP is the same across both courses.
Yeah, that's brilliant. Absolutely brilliant. It depends largely on how you prefer to learn. Some people like to crank through it. And I have to say, I've sat through several of Ben's 2-day courses, and you're completely engaged for the whole time because he's just such a brilliant teacher. And I haven't sat through a night school one, but that is just a different pace of learning. So
Yeah.
thank you. Thanks, Ben. Totally enjoyed
Pleasure.
that. We've had some lovely comments already. If you are interested in joining Ben's courses, the links are in the chat. I will also email those out to you this afternoon. And that's it, folks. Ben will be returning in September with another live, and there'll be some other ones before then. So do join us again if you can. If not, catch up on the YouTube channel. Enjoy the rest of your day. Thanks so much for joining. Take care.
Take care,
Bye.
everybody. Thank you.